This is a case report of malposition of left internal jugular central venous catheter into the internal mammary vein and setting of central venous occlusion. My name is Siobhan Delaney, and the other authors that contributed to this case are Drs. Devane and Kamal. So central venous access is frequently required for prolonged intravenous antibiotic therapy. The use of ultrasound guidance has significantly reduced mechanical complications. However, catheter malposition may still occur, particularly in patients with previous instrumentation or distorted venous anatomy. Malposition into smaller thoracic veins is rare, but clinically relevant due to risks of vessel injury, thrombosis, and ineffective therapy. So the case is that of a 54-year-old female who is being treated for MRSA bacteremia. She was referred for central venous access on a Friday afternoon prior to bank holiday weekend, where PICC line insertion could not be facilitated, and she'd had multiple failed peripheral IVC insertions earlier that week. Positioning in this case was challenging due to kyphosis and scoliosis, and the patient also had a scar on the right side of her neck from a previous VP shunt. Ultrasound assessment showed a short stenosed right internal jugular vein, but the left internal jugular vein appeared patent and of adequate calibre, so therefore this is the side that was chosen to cannulate. On insertion, the guide wire encountered mild resistance at about 1.5 to 2 centimeters. It was withdrawn, and on reinsertion there was still ongoing mild resistance, but it remained clearly visualized intraluminally. When it was secured, all the lumens flushed easily with 2 yielding free aspiration. A chest X-ray was performed in theatre. This is shown on the top left-hand side of the slide. It demonstrates clear catheter malposition in an abnormal trajectory. The catheter was withdrawn 5 centimeters. However, the position of the left catheter tip was indeterminate after a repeat chest radiograph, which is pictured in the bottom left-hand side of the slide, and the decision was made not to use until further imaging was obtained. A CT the following day demonstrated the tip of the catheter in the left internal mammary vein, and both brachiocephalic veins were severely stenosed or occluded with extensive venous collateralization within the mediastinum. The CVC was removed, and the patient went on to have a successful PICC inserted the following week. So in summary, malposition of the CVC into the internal mammary veins is rare but has been reported. It's most commonly via the left-sided approaches due to the left internal jugular vein having a more horizontal course and proximity to the internal mammary and superior intercostal veins. In this case, undiagnosed bilateral brachiocephalic vein occlusion with extensive collateral formation likely redirected the guide wire and catheter. This highlights an important limitation of ultrasound guidance, so while it confirms vessel entry, does not confirm downstream patency, and CT imaging provides definitive anatomical clarification. Resistance during guide wire advancement, even mild resistance, is a recognized warning sign of potential malposition or venous abnormality. And the use of malposition catheters has been associated with complications, so the decision not to use a catheter in this case was pivotal in preventing patient harm. Thank you.